Good evening. Good evening, friends, colleagues, and esteemed guests. Welcome back. My name is Dr. Caroline Lee. I'm an anesthetist in private practice in Johannesburg with a very keen interest in the future and sustainability of South African healthcare. I'm a member of FOSHI, who, with the Africa Telehealth collaboration, bring you this artificial intelligence webinar series for healthcare professionals. Can you believe it? Today is installment number 5, and what a journey of discovery it has been. We started with an introductory session on simple concepts, machine learning, data, and AI training using the data. All of us having already understood and are comfortable with using standardized medical terminology and coding systems, which are the essential building blocks for digital healthcare. We then introduced AI tools, incorporating natural language processing and speech recognition technology. After all, healthcare, as we know, generate copious amounts of paperwork, from clinical notes, discharge summaries, pathology and radiology reports, lab results, you name it. Not only do these tools digitalize and enable paperless systems, but also sharing of data using electronic health records, predictive analytics, telemedicine, and clinical decision support become commonplace. I hope many of you have already started using some form of these digital tools that we have showcased. We showcase many practical tools and use cases for AI systems, those being developed and used mainly and especially those used locally. With major advances in medical imaging, diagnostics, and risk prediction, AI systems can assist healthcare professionals in every aspect of our professional work, from easing administrative burden, voice to text, technology and report generation, to clinical decision-making, to diagnostics, to remote monitoring, to back-end operations and logistics in our practices. It can even talk to patients and work with them on our behalf. Since then, artificial intelligence has grown in an explosive manner and will continue to do so. Q1 of 2026 has seen the highest global funding for digital health to date, to the tune of $7.4 billion and increasing. For the general public, OpenAI using generative AI technology has shown that artificial intelligence could not only analyze data, but also generate human-like language, such as writing a motivation letter to insurance for us in the tone that we want to use. And frustration would be the word that I use most of the time. Summarize information, answer questions, and assist with complex workflows using agents, agentic AI. It is increasingly entering real-world medicine in many different specialties. And we're excited to be able to showcase a few real-world use today. With the development of neural networks and now generative adversarial networks, AI can even assist us in training AI models, detecting inaccuracies, and reinforcing the robustness of our systems at a speed and complexity that we humans cannot even emulate. But at the same time, healthcare faces important questions about ethics, privacy, bias, regulation, transparency, data security, and patient safety. We want to know, how do we regulate, police, and assign responsibility should something goes wrong. Today, we are honored to have a large panel of experts who will showcase real-world usage of these systems and tools, and we will have some of these questions on policy, regulation, and governance answered. So before we start, some housekeeping rules as usual. This webinar is accredited for 1 ethics CPD point. Yahoo! If you are registered, you will automatically get your CPD points allocated at the HPCSA. Any queries should be sent to cpd@discovery.co.za. But please wait 4 weeks before you search for that elusive ethics CPD point. If you dozed off during this webinar, you can access it again after tonight at the ATC website. The link will be in the chat. Also, click on the Q&A section if you have questions, and if time allows, we will answer as many as possible. Otherwise, we may incorporate them into the next webinar. So don't forget to ask your questions, and don't forget to answer the poll at the end of the webinar. It helps us plan for the next one. Should you be in the overflow and have been moved to our SAMA YouTube channel, there's a link at the bottom of the screen for you to complete your details and enter your HPCSA number for CPD allocation. Don't forget to enter your prefix, such as MP, PT, OT, etc. Okay, so let us begin. I'm going to keep my introductions very brief as we have so many distinguished guests and talks to get through. Our first speaker is Dr. Philip Webster, who was in my medical school class. Can you believe it? Philip is going to show us how digital tools can be used using AI and a few simple tech gears. He's an orthopedic surgeon with a distinguished career in upper limb surgery, as well as having served as president at both the South African Orthopedic Association and the South African Society of Shoulder and Elbow Surgeons. He is a consultant at the moment at the School of Clinical Medicine at Wits University and is actively involved in advancing digital transformation in healthcare. Philip, over to you.
Thank you very much, Caroline, for those kind words. My talk is remote healthcare beyond telemedicine. I have a disclosure that I'm a member of Futureplex. As we know, the South African healthcare system is very fragmented and disconnected. We used to have in the past primary healthcare centers, secondary regional hospitals, and tertiary and quaternary centers. And it's my aim to be able to regenerate this with an effective way. We know that there are many, many digital remote platforms, and these current models are really only applications of synchronous calling using various Bluetooth devices. The current issues with these devices is that the calls are not secure. I've been asked to start my video. The calls are not secure. The clinician is not verified nor authenticated. There's also no record of patient consent and no secure recording of the event. The current transmission with these Meta glasses is only through WhatsApp, which is owned by Meta, and these allow only communication with their Meta glasses, which are from Ray-Ban. So we are developing a system of communication using Meta glasses to allow for three-way live communication that links data to a specific event in time and place, using multifactorial authentication to link data to a centralized database. We use the Meta glasses. These allow us to connect a primary healthcare sister to a GP and to a specialist at the same time. There's secure authentication using artificial intelligence to validate data to the patient, and recording of the whole event is to the database linked to the patient identification. It's going to start, and I'm going to give you a demonstration of how this works, if it works. So every clinical interaction that we have involves multiple pieces, people, multiple devices, and data streams. But what we do is we link every participant, every device, and every data point to a single cryptographically sealed event ID, creating an immutable clinical record in time. So I'm going to start now, and this will be a demo of how it works. So we're going to involve a clinician and a specialist. In normal time, we would send each of these the access code. So what I'm going to do is I'm going to issue the clinical credential to Dr. Omar, and this will generate a random verification number, which you can see is requested here, and that is 71, and that is now authenticated by the doctor. The doctor then, you can see, has been authenticated, confirmed, enrolled there, but she has requested a specialist consultation, so we will invite Dr. Wei Chen to do it. The reason for these funny names is that there's no connection to anybody. Again, the number is here. This is 84, and that's authenticated. Now you will see Dr. Wei Chen is being validated, and at this time, the event ID has been created, and the patient is now brought into the discussion. He is registered, consent is taken from him at this time if possible, and we start the live consultation. So again, we're validating what is happening, and now we go on to we have the patient vital signs being recorded, but you can take any metrics. This is now authenticating the meta glasses, which are there. I apologize for the video.
And casting of a fracture of distal radius.
I believe you can hear the video now, the audio.
Analgesia is given to the patient with
Okay, I'll mute it, and then we'll continue. You can watch it there. And I'll show you the clinical records we can generate. So we can put in an observation, clinical observation here as much as we want. The system will automatically draw up a ICD-10 code for you, but you are possible to change it. It'll also list the thing as urgent, non-urgent, or critical. And through this, we can get the event log and all the binding. These are sort of technological things. And what we can do is we could go back finally to the video, and hopefully you'll see now the reduction of the fracture. I'm sorry, it's not a very good video, and
into abduction and internal.
That's the reduction there. And then what we do is we now, having done that and discussed it, we then now end the clinical event, and we go back into this, and we can now finalize the event, because every data point participant every second is now in a tamper-proof original record. So we finalize the event. It is summarized in where we are, and if we want to, we can open the event recorder, and this is a calendar of all the events that have been recorded by you on your computer. And if you look over here, you can see that the patient consent has been created. Patient consent, but not for the latest one, because we're still requesting the confirmation of everything. So once you've got these, then you can then review your clinical event, and it takes a little bit of time. There's a lot of data there. And here you can see the consultation. This is this morning. The same doctors were present on it. They've all been verified, authenticated. There was a clinical tablet. There was a thermometer. There were smart glasses. And here are the recordings that were done. And once we've been through that, we can verify the integrity of the records, and then it will be confirmed on the slides. I'm going to go back to the presentation. So what are the applications? The applications are wide. First of all, we can reproduce the 3-tier healthcare system. We can use it for remote consultation and support, immediate anesthetic casualty or ICU support with consultants, specialist virtual consultation, and also virtual consultation from schools and sports events and hospitality venues before paramedics can arrive. But at sports events, the team doctor could contact a specialist and ask, particularly in international events, whether the player can go back to the field or they need to be admitted to hospital. So what is the end game? The end game, it's a bit of a complicated slide, but what happens is currently we have registries, we have electronic health records, we have AI dictation systems, and these are all linked in a lockup table with field mapping and value translation to ensure that all the data is correct. And then we end up with a single ingest endpoint through the FuturePlex API, and this will develop a common standard. And this will be discipline dependent. There will be subcategories into shoulders or knees or hips. Then they can be procedure related, and we will create then a minimum data set for every specialty, including GPs, if they have registries. This is linked to the patient ID, the event ID, and the clinician ID, and we then produce cross-system outcome analytics based on the registries that are there. So this is not just another electronic health record or registry. It is the layer below these registries, these EHRs, and it is the identity that links patients across all systems. It's a translator that makes incorporatable data speak the same language, and a system that combines data from registries to allow for monitoring and follow-up of patients. Essentially, it's a system that combines all EHR registries together to create a unified, secure database. In this, we will provide minimum data metrics for all specialties, verified by their associations. We will have an advisory committee of the heads of the associations to provide integrity of the system, and we'll have the ability to combine all registries together to create regional, national, and possibly international registries. These registries will generate patient-recorded outcomes to allow for comprehensive outcome measures. So the future is coming, and in summary then, we have a remote consultation that allows this visual and auditory communication with secure transmission of data, authentication and validation of all parties, secure recording of the clinical event, and once verified, data sets can be sent to registries. Thank you very much.
Thank you. Thank you, Philip. That is amazing. Okay, so we'll go on to our next speaker, who is Dr. Kavir Rattan. Dr. Kavir is a dentist who lectures locally and abroad on current concepts in digital dentistry, adhesive dentistry, and restorative dentistry. He's the clinical director of Rattan & Co. in Granger Bay in Cape Town, and is a key opinions leader for GC and Ivoclar. He will show us how AI-assisted imaging interpretation and 3D printing assist him in treatment planning and in his dentistry work. Kavir, over to you.
Hi, thanks for thanks for the intro. Let me share my screen quickly. Sorry. There we go. So yes, I'll jump straight into this. I think in dentistry, there's a lot of technology involved in us being able to give our patients more precise treatments in a shorter space of time now. There was a period of time where everything was kind of done in a very analog way, from models taking time to stone models taking time to set, which obviously delays the processing of restorations or prosthesis that need to be planned for patients. Nowadays, everything is a lot more digital, and from CBCTs to 3D printing to chairside milling and scanning, and it's just improved efficiency all around in terms of the software used for designing, whether it be restorations or implant planning. Or surgery for some of the oral maxillofacial surgeons. So there's AI and digital forms of technology are simply sort of very well integrated into dentistry at this point. And right from a basic thing like note taking, a few years ago I purchased this. It's like the size of a credit card. It's called Applaud. It's fully integrated with ChatGPT. And I basically am, I do my consultations and with my patients and my discussions. By the time I'm done with my session, obviously this has produced an entire summary of the entire meeting, as well as everything that was discussed between myself and the patient. So that makes note taking a lot easier for me, especially when you're a very busy clinic. It allows allows me to go back in and make any minor changes I require in my notes, and saves me pretty much a lot of time. When it comes down to examinations, diagnosis, and analysis, we've got CBCT technologies in our offices, and obviously with the CBCT, we're able to do a lot more investigation on patients, and we're able to see far more. But with AI technologies like this logo on the left here is a software called DiagnoCat, which basically, by the time you've completed your CBCT in your rooms, you would have had a complete interpretation of that entire CBCT related to whatever field of view you've taken. This software will immediately highlight, for example, the important areas like nerves, such as inferior alveolar nerves, mental foramens, sinuses, whether the patient's got a cavity or a fractured tooth, periodontal disease, pockets, any of the main things that we're actually looking to interpret. This software will do for you, which is fantastic. And in a sense, you also get when the patient's done at the end of the session, we're able to give them a printout of that exact findings on the radiographs. And you'll see even on this little video that's playing, this is basically sort of STL file of an intraoral scan that's been taken of the patient. We can then overlay that with the patient's CBCT, do any sort of surgical planning. For example, in this case, an implant's being planned, and a surgical guide has been fabricated, which is 3D printed, and you can place your implant through that tiny little hole here. So that helps us reduce any morbidity and reduces the sort of surgical risks that can happen during these procedures. In terms of, for example, from a cosmetic point of view, this was just a still image that was taken, but I'm able to, using specific softwares, take those images, and the AI allows us to give you a simulation of what the patient would look like when they're smiling, when they're talking. So I can present that to my patient to give them an idea of what the future plan for their smile could be before we've even lifted a handpiece to touch their teeth, for example. So the patient's fully involved at this point, and they can get an idea of where their treatment's headed. This is a great diagnostic tool, because they're able to tell us what they dislike, from a thing like the form of the tooth, the shape of the tooth, the length of the tooth. All of those things can be changed digitally and quite rapidly now. These are things that had to be done manually by hand and wax before. Now it's done in softwares like exocad, and it takes fractions of a second to make these changes. The little device on the right-hand side is called a Trios 3-shape intraoral scanner. This takes thousands and thousands of images in the mouth to create a CAD or 3D model of the patient's oral cavity and their teeth. This means that I don't necessarily have to take an analog mold of the patient. I can send these scans to my lab via the software, and they can have a very, very accurate scan of this patient for us to work on, instead of now waiting for someone to come and fetch these models and then pour them. And so this is really created a lot more efficiency, and it's cut out a lot of time wasting for us. And these softwares now allow us to do a lot more. For example, if a patient requires orthodontic treatment, and I can take this particular scan and do a simulation using the internal AI on the software to within a minute or two to show them exactly what their teeth would look like when they're being orthodontically moved into the correct position. So they can see it in real time, what their skew teeth would look like once corrected. We can give them an idea of the timelines of how long that would take, and the amount of treatment involved in that. So from a digital workflow, we're working with intraoral scans daily, which we're converting to STL files. STL files are basically these little files that are printable. We use CBCTs. exocad is a design software. We're using smile analysis, chairside CAD/CAM, and I'll go into this in a few minutes. This is sort of using AI and digital dentistry is a very, very vast topic. And obviously, I think with the amount of time I have, I can't go into all the detail, but I can give you an idea of what's going on daily in our clinics. So the image on the left and the right. Okay, so on the left is a chairside system that is called a CEREC. This allows you to prep, for example, a patient's tooth that may be fractured or required some sort of restoration. There was a time where labs were carving these sort of things out of wax on stone models and having to do the sort of wax burnout technique. But now we have, AI libraries with thousands and thousands and thousands of occlusal surfaces and morphology for teeth. So within a few seconds, we're able to render the correct morphology for that particular patient. You'll even see these little marks indicate the amount, the red indicating how much of pressure the opposing tooth is applying. Using software, we can adjust those areas to make lighter contacts between teeth, so you don't have teeth that are proud and high that need a lot of adjusting. And we can then tell these computers what sort of materials we want to manufacture these restorations in. And what it would then give us is, within a few minutes, if you have a chairside milling system in your office or 3D printing system, will give you a very lifelike restoration that can be placed in a patient's mouth. So these scans, for example, these intraoral scans convert to STL files, which we are using now on a daily basis. And we can send these specific files to our design softwares, design whatever it is we want to design, whether it be a surgical guide for implant placement, whether it's a night guard for a patient who is a bruxer or grinder. We can then, using artificial intelligence, have these softwares design the specific prosthesis, restoration, whatever it is we want to design, and place it in these machines that will either, on the left-hand side is something called a SprintRay 2 machine, which will literally 3D print your restoration for you. Depending on how many restorations or whatever it is you're printing. If you're printing just a set of models or a single tooth, these things can take from a few minutes to a couple of hours. And on the right-hand side is sort of a CNC type robotic machine called a prime mill that will literally mill out the entire restoration that you have designed using this technology. And you can then have a restoration ready for cementation. You could even use, you could mill a surgical guide if you don't have a 3D printer. So there's a lot of ways for us to improve the efficiency and cut down the amount of time it takes for us to provide patients with treatment options. So if we look at finished products on the bottom left, these are 3D printed models, no longer stone models, with a 3D printed surgical guide for a patient that's having an implant surgery done to replace a missing front tooth. We're basically doing this surgery outside of the mouth first to make sure that we were able to accurately assess the size and the design of the implant that we want to use, whether the patient needs grafting. All of those things can be predetermined before we go to the mouth, so that there is very little risk of trauma or damage to any sort of sophisticated structures in the head and neck area. The middle picture is, this is, if I look at the conventional way we did things was, to make a patient a set of dentures, for example, you had to take, that took a few visits, patients coming in numerous times. Now you can digitally scan this patient, have your technology design the prosthesis, and you can then print the pink portion, which is the gum, print the tooth color, design, the AI will help you design the correct shapes for that patient's face, because everything's 3D planned or facially driven. And then using specific bonding agents, we can then merge the two, remove those little sprues, and the patient can have a denture almost instantaneously. And on the far right, that picture is for a patient who may have had some veneers prepped. We can, again, scan this patient, use AI to help us design what those teeth should look like. And when that patient leaves, we can then put in some temporary restorations So they already look amazing, and that gives the laboratory time to then process and actually make this patient some really good-looking ceramic work, which can be delivered sort of a week later. And even coming down to single tooth restorations, you can make these contact lens type restorations. The same, either milling it or printing it, depending on what type of material you choose to use. You can then take it to the mouth, and you have a very, very natural looking restoration, which would last a very long time. And then we're looking at the future of dentistry, and we're actually in this phase at the moment. The machine on the left-hand side was designed by a very world-renowned dentist named Galip Gorel. This is called a Lupin robot, and this machine has been designed to prep the veneers for a patient. And obviously a dentist has to be present, but for what it's worth, all the hard work is done by this robot at this point. In terms of the accuracy of this machine, we can now process and make all of the veneers or restorations for this patient before their teeth are prepared, because they should fit accurately once this robot has prepped that patient. So I think in the near future, could probably go in and on the same day have very beautiful ceramics put in almost straight after your preparation. But I think that would be a very long day in your life. And then the robot on the right-hand side is for surgical implant placement, which is robotically guided to place a dental implant or numerous implants in one sitting in the dental chair. So in terms of the artificial intelligence that's being used, this is, thank you. That's basically covers our lecture. Thanks very much.
Thank you, Kavir. It's amazing how everything has developed so much. I can still remember trying to find a 3D printer during COVID for somebody to print those mask hooks for those face shields. Anyway, our next speaker, Dr. Amban Pillay, I'm sure is well known to many of you. He's the current co-chairperson of the Africa Telehealth Collaboration and the chairperson of the United Forum of Family Practitioners. He's the CEO of the Alliance of South African Independent Practitioners Association and the Independent Practitioners Association Foundation. He is also a full-time family practitioner in a multidisciplinary family practice with special interest in digital transformation, innovations, outcome-based care, and chronic disease management. There is a saying, if you want things to get done, find the person with the most on their plate. Well, Amban is the man. Amban, please show us all how you manage to do what you do, leveraging AI.
Thanks, Caroline. Please tell me if you can see my presentation. I'm just putting it in. Here we go. Can you see that?
Yes.
Good. All right, thank you. So I'm going to just focus on primary healthcare, specifically the general practitioner, and some of the tools that we have, specifically the AI tools. I think we've been in the series talking a lot about what this AI is going to be like, and a lot of concerns about whether the AI is going to replace us or not. But I think as much as the future is digital, what we see now is that it's the AI plus the doctor versus disease, rather than AI versus the doctor. And the AI tools, I think there's a whole host in primary healthcare, because our profession is such a vast profession with so many disciplines. If 2 or 3 years ago I was most excited was with the diagnostic tools. There was a lot of really cool things we could do with AI tools, and I'm gonna show some of that today. But I think as we starting to evolve and we're starting to have a better understanding, I think the administrative tools is really where I think a big focus is. So the AI-empowered GP is really a GP that has his time freed up because from all the admin and the admin burden that we've seen using really smart AI tools. And so we've seen a lot more AI agents being created to give us more time. And so the AI agents and the AI tools that we see developing now are almost assistants, co-pilots for us to work with us and alongside us to actually make us better clinicians and give us more time to do what we do best, which is, be a doctor and spend time with the patient. In my practice, I've divided the tools into three categories. So diagnostic tools, which we'll, see a few of. There's quite a lot in that space. And then some of the more important ones is the clinical insight tools and the administrative tools, which I think for me I'm most excited about. So in the EHR world, and we've spoken a lot about EHRs and AI scribes. I think what's important is firstly, most of us, majority of GPs in solo practice are still in a paper-based environment. But as we move from paper to paperless, I think we're moving. What's good is that a lot of doctors can jump the old clunky systems, systems that you needed servers for and needed to do backups into new cloud-based and what I call smart AI EHRs. And these are AI tools and agents that are built into your EHR. So I use a system called HealthBridge. And besides all the nice things that HealthBridge does, like, the timelines and the medication, the ability to do e-scripting and sick notes, they've built very nice tools into the EHR so that sits integrated into your patient's timeline. So, some of on the left-hand side, we see 5 real agents, and each one of these agents does a specific thing. So you could, within a click of a button, ask it to do a visit summary. So each time you're a patient, you open a file, an AI summary pops up to say, look, this is where the patient is, this is where the last results were, this is what's outstanding, this is what's still due for a patient. You can create custom documents, medical history summaries. I think Caroline spoke about the motivational letters, and these are really built in. What's nice about this is you're not taking information and putting it into a large language model or ChatGPT. It will read your timeline, it will read your medication, it will write a referral letter specific to your patient and what it reads in the patient's file. And so the information, firstly, it's ring-fenced and it's also safe because it's not out in the open. So it's compliant, it's POPI compliant, and it will write the correct information without you having to add into ChatGPT or Claude or one of the other models. So this assistant now is becoming really, really good. It will create summaries, it could create follow-up appointments, it could create calendar appointments, all automated and at the click of a button. The second aspect, which is the clinical insight aspect, and this is really also built into the EHR, is that from a clinical side, you can ask it, treatment plans, you can ask it treatment guidelines on a specific patient. Or as you write in the notes, you can ask it, information on whether the recommended treatment you want is going to interact with some of the chronic medication that's already there. And this is again built into the EHR of the patient that you're using, and every single time you open your EHR, you can get these clinical informations. The pathology one is really cool. What happens at the moment is all our pathology gets pulled into our EHR as a PDF and gets stored in the timeline. And the pathology assistant now will go in, read the pathology on a daily basis, create a short WhatsApp message, and interpret the results for you. And before you would need to have to phone the patient or ask the patient to come in, the AI tool will then give a short summary which you can read and then click yes. It will send a WhatsApp to the patient to say, listen, your HbA1c is 8.2. It's actually better than it was the last time. We're very happy with you. Please continue. Or we're not happy with you. Please come back and make an appointment. And all of that is automated. So the patient will receive a WhatsApp message to say that your results have been received, your results have been analyzed, and your doctor's happy with it. And, in a click of a button, we can then go to 20 or 30 patients' pathology in a few minutes. So the EHR for me is probably one of the biggest opportunities to build a lot of these AI tools and agents in. I think we're already starting, and so they're live, they're working, and they're in practice. Some of the tools that we're building at the moment is really around population health, and we're building tools to analyze the large data, so your practice data. So to give us information about what's in your data, how many diabetic patients you have, how many diabetic patients you have who have not done the pathology or have not done an ECG, or how many patients have abnormal results and need to be come back. And so the new tools will be able to analyze your patients. They'll be able to then pull out those patients that are outstanding for appointments and send them a WhatsApp to say, listen, you're due for an appointment. Please come in to see your doctor. So this way, one, it helps us to manage our patients better, but it also allows us to get more patients through the door. And, from a population health and what I call a practice health point of view, it means that we're going to get better compliance and we're going to get better patient care. So, I think the clinical insights, the clinical assistance, these are two of the most powerful things we have. Some of the diagnostic tools that are available, and there's quite a few. I've chosen 5 just to showcase in this talk. So this is the Echo 500 digital stethoscope. It's got a small screen. It's got a 3-lead ECG on it, and it is able to do both cardiac, bowel, and pulmonary modes. And so it's AI tool that sits on your phone will be able to diagnose a murmur. It will be able to diagnose the atrial fibrillation, sinus tachycardia, bradycardia, all automated just by you using the tool. So the stethoscope can actually sit with a GP, with a primary healthcare nurse, and it will work as a cardiologist assistant for us. It will give you the heart rate, a single lead ECG on the screen, and the most important, it will assist you in actually diagnosing what you're hearing. It's got all the benefits of a digital stethoscope, like noise cancellation. It can be used without the earpiece, and it could be used with, AirPods as well. But I think that AI tool that's linked to it makes it a very powerful tool in a resource-limited setting. So you could be a nurse in a rural area that doesn't have access to a cardiologist, listening to a pediatric, and it will be able to diagnose that murmur for us. This is also a digital stethoscope. That's actually the full stethoscope, this little device that sits here. You use it almost like a little, door handle that you put on the chest. It's also meant for primary health care. This is a company based out of Cape Town called AI Diagnostics, and they've developed a tool and a digital stethoscope that can 90% accurately listen to a chest and diagnose TB without a sputum or an X-ray. And so from a screening point of view, we can really see a lot more patients. We can screen patients. We can diagnose. And it's not just TB. The AI tool is diagnosed for TB, but soon it will be able to do silicosis. It will listen to a cough and be able to diagnose the specific pulmonary disease. And so as we screen and pick up more patients, we can then spend the resources to do chest X-rays and things to confirm and start treatment. But at a 90% sensitivity, this gives us a very accurate device that again can be used in a primary healthcare setting to screen patients at large. Again, digital otoscope, same principle. This is a little camera, LED camera that looks at the ear and is able to diagnose very accurately at 94% accuracy, the ear pathology, whether it's a perforation, it's an otitis media or externa, and it gives us the tools and maybe the second opinion that if you're not so sure about what you're seeing, that it will be able to assist us as that clinical assistant role that I talk about all the time. And so this is also something in a primary healthcare toolbox that's changed what our medicine bag looks like. Point of care sonography has become quite a commonplace in primary healthcare. We have an ultrasound probe that the full ultrasound is the size of your cell phone and gets connected to your cell phone either wirelessly like the Clarius probe. This is a Canadian company that's built AI solutions. So you can use this sonar to do a sonar of the cardiac, a carotid. You can do it for facial sonars. You could do it for vascular, and the AI tool will, on your screen, it will identify the different structures. It will tell you what you're looking at. And they've built tools that now will be able to diagnose disease. MedSol AI solution, it's a company out of Pretoria. It's a prof radiographer that developed this company that's able to diagnose breast cancer using the Clarius probe at a 97.6% accuracy in a non qualified person. So it's not a radiologist or a radiographer. This again can be used by GPs and nurses to screen patients in a primary healthcare setting. And, I mean, if you compare it to a radiologist, which is probably at a 96%, and a GP, which is probably at the 89%, the AI tool gives us a much more accurate tool that we can use to do screening and to be able to pick up disease in a primary healthcare setting. I think this is the last one that I wanted to showcase. So this is a new one. It's a continuous glucose monitor. So it's a little device the size of a 5 Rand coin that we stick in our arm that reads continuous glucose. And so this has been around for a while. And what they've done with this specific one, this is the Accu-Chek one, is that Accu-Chek has linked it so that once you use the continuous glucose monitor, it will give you the results like the blood glucose readings, but it's also linked to an AI tool that will predict what your blood glucose is going to be 30 minutes in advance or 2 hours in advance or throughout the night. So what does that mean? It means that before you get the hypoglycemia, the AI tool will predict that you're going to get the hypoglycemia before you know that your actual reading is low. So on a normal reading, the AI tool is able to predict either very high or very low so that you can adjust your dosage of medication, you can adjust what you're going to eat. And in diabetic patients, especially elderly patients or patients who are on insulin, one of our biggest challenges is, besides the control, is actually the hypoglycemia, the low glucose. And so this tool is very powerful now, and it's made a continuous glucose monitor really a predictive thing, which means that you can use the tool and the AI tool to really, titrate your dosage, titrate your insulin, and be able to pick up any lows or highs before it actually happens. And I think in primary healthcare and just generally, these agents are really shifting and changing how we practice as clinicians. And I think that's my last slide. Thank you very much, Caroline.
Thank you, Amban. Thank you for sharing the tricks that you use to become superhuman. Okay, so our next speaker is Dr. Stephen Cook. Stephen is an ophthalmologist in private practice and a senior lecturer at the Walter Sisulu University. His clinical expertise spans vast fields of ophthalmology, alongside leadership roles on multiple National Ophthalmology Society executive committees. His strong interest in AI in healthcare has led to the development of the Screen for Life Diabetic Retinopathy Screening System. As board member of Africa Eye Foundation, he's leveraging AI for screening and early detection of systemic and ocular disease in primary care settings. Stephen, please show us what you do.
Thank you very much. I really appreciate your introduction, and thank you to Kuzi for sharing my presentation, which I unfortunately didn't manage to get onto the platform, but we'll do it as a PDF. So thank you. My title is then AI to Screen for Life. Let's move on, if you wouldn't mind, Kuzi. So first realization we have to have is that the eye is part of the brain. In fact, the eye is the brain. If you think of the brain as an organ and we get to be able to visualize it, we can have a metabolic balance sheet that incorporates neuropathy and vasculopathy. Thanks, Kuzi. Next. From our embryology, we know that the eye, in fact, develops as an outpouching of the brain. And interesting demonstration of this is that the 10 layers in the retina are mirrored in the 10 layers in the cortex. So the eye is part of the brain, was a major realization for me early on. Let's move on. So thanks, Kuzi, next slide. So if we get to look at that, we get to see neurons and vessels let's move on, with vasculopathy and neuropathy, which, thanks, Kuzi, next one, which has common pathways for diabetic retinopathy, glaucoma, age-related macular degeneration, which we may think are eye diseases, but also for renal, cardiovascular risk, central nervous system risk, and dementia risk. So in terms of what we're looking at when we look at an eye with a fundus image, and these are just pictures of two ways of capturing a fundus image. The retinal fundus is the picture, how we refer to the retina that we see when we take it with one of these cameras. This is a handheld one being demonstrated on the left, which enables us to be mobile and to reduce the cost of capturing the images, and a desktop version on the right-hand side, which even allows automation. So this then is a picture of a normal retina, if you like, at ease. And even on this, you can appreciate how we get to see the vessels, the nerve, and the retina. And from this now, in terms of AI analysis, we can actually determine a huge amount about this person, right down to the gender, age, smoking exposure, and so on. Next, please. Diabetic retinopathy, of course, is the leading edge of this for us, because it's an ideal disease where there are elements of neuro and vascular damage, as well as the manifestations in the retina of retinopathy. So this has really been a key area that has led to the AI incorporation, next please, into our healthcare. Tianyan Wang out of Singapore has really made this a life work. And basically he says that any retinopathy represents a significant and systemic risk for complications, basically doubling the chances of any complications the moment it is detected. This led us to develop the concept of a metabolic approach to screening of retinal fundus images, and hence the Screen for Life campaign. Next, please. There's no such thing as a little bit of retinopathy. Being retinopathy positive indicates extremely high risk for ultimately death. Thank you. Next. Humans need help. And next, please, in terms of our grading ability, this was work we did in 2013, looking at the grading ability of a group of graders in South Africa. And what we see here is just a really shotgun spread of different performances, with very few in the top left-hand corner. Now, AI in ideal settings sets a new standard for grading in validation studies in excess of 90% sensitivity and specificity. Let's move on. The outputs that we get would look something like this and be graded as non-referable or referable. We like our technicians to actually comment on them, and where we're dealing with paper, they can write on them or comment just to give some sort of human verification of the outputs, and to provide the first opportunity to counsel people who have been screened. Let's move on. There's a huge amount of data and evidence-based medicine here, but interesting to follow Anbin, who says it's the AI and the human against the disease. AI and human hybrid models enhance the detection and the cost effectiveness of systems. So very much supporting what he's saying. Thank you. Let's move on. Extraordinary that AI can see the unseeable. Next. RetiFino-Age is a very new wellness AI that enables us to use a deep learning to mark and establish a overall morbidity and mortality prediction. Now, this, if we consider this in a wellness setting, let's have the next slide, enables us to move upstream in our endeavor to care for people. And as I say, human needs help. If we can detect things before they become a problem, our interventions and healthcare, healthy living lifestyle interventions are much more effective, and in a cost-constrained system, possibly the place we should be. So this is one of the areas that is quite astonishing, that AI can look at what appears to be a completely normal retina and detect the morbidity and mortality prediction. Next slide, please. As humans, we can't actually see this, and this is where this is quite unnerving and disruptive from a human grader, particularly a doctor's point of view, because we can look at a normal-looking retina and detect end organ damage. As mentioned, renal, retinal, stroke, dementia, central nervous system, cardiovascular, and peripheral vascular risk. Next. This is, of course, very interesting to insurance funders, wellness, things such as the Discovery Vitality System, medical cover, in terms of life insurance, obvious benefits. And in terms of looking at then what was Dr. Webster spoke on earlier about an integrated digital health model, if we can put cameras into the community, we can actually coordinate care from a primary level and inform some primary level care steps for individuals. And so we move into the concept of personalized medicine and precision medicine. Let's move on. If we look at this metaphor, we started off looking for at blindness prevention. We are now expanding this into looking at systemic risk and now into wellness. And so I think this is something that AI has enabled a complete paradigm shift in terms of how we view screening and how we view healthcare and how we might use these technologies. Next step. Next slide, at least. So we need some sort of platform. We have formed a partnership as SugarWave. We have formed a partnership with AI Connect, which is an HMO, to help coordinate our dealing with the profession and with funders and come up with next slide, a coordinated model that enables AI implementation. This is a slide from Professor Wong, just documenting the progression of how screening has changed from being something that specialist ophthalmologists did to generalists, shifting from film to digital and telemedicine, and now from human to AI. Let's move on. I consider myself to be a serial failure in that we started with the Screen for Life after Prof. Wong visited us for a vitreoretinal conference in 2008. And since then, I've been punting Screen for Life and failed over many, many years. And you can see some of the relationships we've developed, some of the timing here, and there've been a huge amount of things that have been really great, should have worked, but not this year. Next, please. So part of this is really saying we have to keep trying, we have to keep punting what seems to work, and as experts, perhaps we need to try and discriminate what is going to work. A great success was the CDE system. And really what this did was to create the platform where we could coordinate care from primary health care all the way through to specialist care. And I think this is then a really important part of what we say, is saying it's great to have these applications and incredible technologies, but they need to fit. And this is really our next step in terms of what we're trying to do, working with AI Connect and the various professional bodies to coordinate our care. Next, please. So Screen for Life, Screen for Progression, and Screen for Sight, Screen for Progression, and Screen for Life. Thank you. That's it.
Thank you, Stephen. And wow, excellent work. Thank you so much for everything that you do. So now we come to an amazing showcase, how generative AI can be used to great success using a digital companion. So we are on to our next speaker, Stephen. Thank you so much. We're asking Ms. Natalie Merich, who is a senior product manager at Audeer, combining private sector project discipline with on-the-ground public health implementation experience across South Africa. She has played leading roles in designing and deploying multimodal AI companions across 5 African countries, working with the Ministries of Health to find responsible, human-centered AI solutions for complex health and social challenges. I can talk about what she does for many more minutes, and I would rather give her the floor to show you the amazing work that she is doing in her own words. Natalie.
Thank you so much, Dr. Lee. It's an absolute pleasure to be with you all today, and thank you so much for the time. I believe that everyone can see my screen, but if not, please just raise a hand and we'll correct it from there. Great. So I think first and foremost, a lot of my fellow panelists have talked about AI at work, specifically inside clinics, healthcare facilities, and so forth. And I would really like to take the time to talk to you a little bit about the space between those visits, which are perhaps the other 364 odd days a year. So in South Africa, right, we're looking at approximately 5% of people living with HIV that don't know it. That's only one statistic. And when we extend that to other areas such as sexual and reproductive health, gender-based violence, mental health, NCDs, and so forth, right, this continues to expand in so many different ways. Now, these individuals aren't necessarily in your waiting room, but they are asking questions on WhatsApp at 11 o'clock at night. And this is where that early detection and preventative screening can actually happen. And that is where Outerway Africa works, with really the intention of developing AI-powered tools to deliver safe, equitable access to healthcare, specifically at the individual level in this particular case. Now, part of our foundational work was really understanding that globally, no country has deployed a single standalone app or system at scale in healthcare. There is always a mosaic of tools, platforms, and different integration points. And so what we really focused on was building a modular AI integration toolkit, which has 4 interoperable services that can plug into whatever a health system, NGO, government program, or partner already has or needs. We have computer vision for diagnostics, we have AI companions for conversations, predictive analytics for intelligence, as well as a hybrid safety layer. And with great power comes a great responsibility. It's not just about can AI be trusted. The better question here really is how do you build AI that earns trust and can prove it? And for us, that really meant three core components. Safety, which is do no harm. Value, which is provided by ensuring co-design with the communities that that tool serves. And then cost as well. So ensuring that it's optimized so that it can scale affordably. And so building on that foundational work, this is how we actually built our self-care from anywhere model. And that's what I'm going to be talking to you and sharing some of the insights about this evening. So what we did is we took different components from our toolkit and integrated that into a WhatsApp AI companion, which means that it's localized, available 24/7, along with local language support. So what this allows for is for that preventative screening, whether it's HIV risk, TB, sexual and reproductive health components, depression, anxiety, self-harm, and so forth. And this is all embedded in a natural stigma-free conversation, not as a separate form or as siloed data. We also incorporate personalized nudges that can be determined by the relevant healthcare pathways and is triggered by what users share to actually improve their health journeys. And then critically for this room, we have a clinical portal that shows you risk flags, summaries, and prioritization. And on the right, what you'll see is we have our diagnostics layer as well, which is connected to that very same platform. So a user's diagnostic result connects to their care journey and to their AI companion. So the key takeaway here is the conversation the AI had with the patient about HIV risk a month ago can be linked to their self-test result today, which can be linked to their connection to care tomorrow. What does this look like in practice? So on the left, you have your patient's view. This is what one of our WhatsApp companions looks like with one of the conversations being displayed. And you can see this one is in isiZulu itself. It's available at any time. There's no form, no waiting room, and specifically no judgment. So this is really a safe space that was really focused on creating trust within individuals so that they would be willing to share that information that is really relevant in helping to prioritize their needs. And then on the right, what you see is what you would see as a healthcare worker, and this is the Health Pulse AI clinical portal. So what happens is all of those conversations pull through into this clinical portal, and what you get are AI-generated conversation summaries, risk flags, in particular for areas of concern, and a prioritization queue. So in this instance, the AI really is supporting that triage, and it allows you to step in where it matters. So I want to take a look at the scale of what this generates. So to date, we have over 1.1 million health inquiries. And that is particularly important because it's generating the health intelligence that a lot of funding cuts have actually erased. We have over 85,000 people onboarded across our AI companions in South Africa and Zim and soon Mozambique. We have more than 120 different social data indicators collected per user. So this really provides rich insights at scale than any survey or facility may be able to register. And then finally, we've got 58% of users meaningfully engaging. So that's not just a once-off message of adding a user to your stats. At national scale, this really has the ability to become the largest real-time community-generated health intelligence system and also has huge implications for your community-led monitoring efforts as well. Continuing that thread, I'd like to quickly share some insights. Firstly, just from our AMY study in terms of what we saw. This was a study focused on your adolescent girls and young women, about 9,500 of them. And what we saw once they had started using the AI companion was that 49% of them actually took up care. We saw that 45% of them tested for HIV, and we saw that 41% of them chatted both with AI and with a nurse. So the AI in this instance really was the front door, but it reduced the stigma and it built the confidence to seek care, and then it handed it off to the clinician. Secondly, we've got Subclav, which is a national, well, it's scaled nationally through the BeWise platform and through the Department of Health. What we're seeing is nearly 20,000 young people that have onboarded here with an 86% acceptability rate. And then what I just want to highlight for this room in particular is real-time self-harm as well as gender-based violence detection. And there's some very interesting insights there, especially in what we've been able to determine for your upstream drivers of gender-based violence, as well as your downstream impact. And then thirdly, we have Coach Impilo, which is another one of our WhatsApp AI companions deployed within SA. We're looking at over 79,000 users onboarded there, specifically aimed at those living with your chronic conditions. So thinking about HIV, TB, anxiety, and depression screeners that are also built in, as well as a lot of your treatment retention reminders. One of the key takeaways here, and this reflects to my earlier point, was that we're seeing that 64% of self-harm conversations are happening outside of clinic hours. So what can this mean for you as a healthcare provider? So I think layer one, specifically your patients, right? Meeting them where they are via channels that they use. So if we think about WhatsApp being available, 24/7, being able to collect your 120 different health indicators that you'll likely not be able to capture in a 15-minute consult. I know that, the time spent with patients is absolutely crucial. So your patients in this instance would arrive better informed, more prepared, and with their barriers already surfaced. Layer 2 speaks to the intelligence layer where AI can help with that triage. You're able to see your highest risk patients first and then have that escalation specifically when it matters. And then layer 3, of course, your tools. So really just empowering your teams, having the population level analytics, being able to do possible integrations, automated follow-through, POPIA compliant, so on and so forth. AI can really help reduce your administrative load and can also amplify your clinical impact. And that's just a summary on the right of what can really make this valuable for you. Lastly, though, before I do hand over, I do want to just say to keep in mind that not every nail needs an AI hammer. So what I would like to recommend is that these are the type of questions that you should be asking of every AI tool. And while this might seem basic, it's really important to keep coming back to them. So asking questions around who designed it, asking questions around, is there real-time safety monitoring? Is there human in the loop? How is accuracy being ensured? Is it compliant? Is there evidence? And finally, does it also allow the clinician to remain in control where AI continues to support but not replace? What I want to emphasize is that these are not just technical questions, they are also governance questions and our responsibility, which I believe I have the pleasure of handing back over to Raymond, who will be sharing a little bit more on this in a moment. So thank you so much for your time. Feel free to reach out if you have any further questions.
Thank you so much, Natalie. That was an excellent presentation. Thank you. And I love those the right questions to ask, definitely. So, our government has recently gazetted a really good policy and governance document on AI regulation. Unfortunately, it had to be rapidly withdrawn because someone or some people responsible for this document did not check it thoroughly before submission. So the question frequently asked is then, who is responsible when AI is used and the information is wrong? Here to answer this is Raymond Meneses, a specialist employment attorney, legal advisor, mediator, and public speaker with extensive experience in labor law and workplace strategy. Having served as employee relations executive for mass discounters across the African region, he brings a unique blend of legal expertise and practical leadership experience, especially in his extensive speaker and facilitator roles for leading organizations. Raymond, over to you.
Good evening, everyone. Thank you for the opportunity to share and participate in this conversation. The answer to the question is a fairly straightforward one. The clinician, the medical health practitioner, remains accountable. So I think there's probably going to be quite a lot of panic in the context of how does AI increase liability potentially or increase responsibility as far as any healthcare professional using that AI is concerned. And my advice is don't panic. Whilst we're moving from policy development to governance questions now, and you've pointed out that really embarrassing situation where gazetted AI policy had to be withdrawn because it was generated by AI and there were glaring errors and fabrications and imaginations on the part of AI which weren't picked up by the human users. I think that's a great object lesson for us. The accountable party remains the medical practitioner who's obliged to use AI as a tool, like any other tool, and to check it and to consider it, and to never lose sight of the fact that as professionals, whether in medicine or in law, we remain accountable ultimately for the product, which is the care that we supply to third parties. So my advice is don't panic. The law exists. There is already governance in place. Nothing really has changed, except that there's another actor, and I don't mean actor in the sense of somebody in a TV show or in a movie, but there's another party to the process, and that is an AI party. That's all. It's simply a tool, and it's going to make, in my view, the practice of medicine better and more efficient. The same information is out there. It's just being accessed in a different way. I was telling Brad Byra earlier today when I met with him that when I was an article clerk 1,000 years ago, one of my jobs, which I hated, was to update the law reports by getting a publication from the law reports to say that there'd been developments in law, and I would then go and laboriously look up all of the law reports that were potentially affected by those judgments, and note the citation in handwriting on the existing law reports in our law library. And that took hours. Now I have at my disposal access to thousands of reported judgments, not only in South Africa, but across the globe. and I accessed that through making or making use of search engines to get to that information faster, but I'm still responsible for how that information is interpreted by me and applied. I had 2 instances in the course of a week, recently, in the last 2 weeks, where both a client on the one hand and a colleague on the other sent me advice, which had clearly been processed through an AI channel, and said, is this the correct position under the law? And I had to say to them, no, it isn't. It's partly correct. In the one instance, what had happened was there was an application of American law, whereas our context is unique, it's different. We have South African law. And in the other, only half the story was given. It was a part of the answer, and I was able to bring my experience, 30 years of experience in my field, to say this is not how a judge is going to view it, and there's actually been a misunderstanding of the case law. So certainly, I think AI is very exciting. I think it's going to help medical practitioners in many ways. It's going to streamline the process. I'm excited to see the administrative care that is provided, and really what Natalie Maricic had to say about assisting vulnerable people is incredibly encouraging. It creates opportunities for greater engagement, but the principles remain the same. People are going to be held responsible of those who ultimately carry the responsibility for the care. Nothing new there. The same rules in respect of causation are going to apply. If you have, for example, again, something I was discussing with Brad Bauer this afternoon, an operation which is performed on one site where a local surgeon, for example, performs an incision to allow a laparoscopic process where the person operating the robot or the robotic device is sitting in another jurisdiction, in another country. It's still necessary for the person operating the robot to be registered to practice medicine in the country where the operation actually takes place. If something goes wrong, the person behind the robot is going to be accountable to the extent that they would be accountable if they were in the room. The fact that there's an intervening process doesn't really change the picture, except to the extent that it may have an impact on assessing the extent of causation. That's all. These are legal questions which the courts are enabled and empowered and skilled to a greater or lesser extent in determining, having regard to the current governance measures that are already in place. I don't think the fact that there is a lag between the development of the technology and the corporate or rather the governance measures that are specific to the technology is any cause for panic whatsoever. We already have the infrastructures in place, and it's going to be a matter of refining them as and when the developments occur. And we accept that the accelerated rate of change that is brought about by the rapid, unbelievably rapid rise and sophistication, increasing sophistication of AI could be a cause for concern. Again, don't panic. We're good. That's it. I had limited time, and I think I've stuck to it.
Absolutely. Thank you very much for bringing us back to time. And it certainly is so. I think a lot of the time, it's not what the AI is telling you, but how you interpret what the AI is telling you and use your common sense and your knowledge and your experience to interpret what the AI says. You cannot just take what the AI gives you and then say, well, you know what, the AI gave me wrong information. That doesn't hold up in court, correct?
That is correct. To the extent that you can, you'd still have to verify that it's whatever it is, the diagnosis is accurate, having regard to the other factors available. I don't think it would be wise to blindly rely on any third party, human or otherwise, without actually taking the time and energy to check that that's in fact correct.
Well, that's why you train as a doctor, right? Otherwise, we could just use AI and don't need and get rid of you in the meantime. Okay. Thank you very much, Raymond. So, so that comes to the end of our panels and for our talks. Thank you so much for all the esteemed panelists and all the esteemed speakers that gave so much of their time and expertise and to give us all the information. There are a few questions. A lot of the questions are based on, want to ask the cost of these different AI tools and systems. My suggestion would be to, it may be a good idea to use AI to ask them what the cost will be, and you will get a whole lot of different options available, and you can have a look. And so the questions about cost, whether it's affordable in a third world country. Well, if you ask ChatGPT, which I did, I asked about digital otoscope to ChatGPT just now, and he gave me an option from 150 Rand to over 50,000 Rand. So, you know, there are lots of options available, and you just have to ask ChatGPT, and he will be able to give you a lot of answers on the cost of anything or the types of AI tools that's available on the market. You can ask them available in South Africa and you'll get the answer. So those questions I'm not going to ask our speakers. There are some other questions that's important. I'm not sure who to ask this. I think, Raymond, will you be able to answer this? So are we, you know, when patients' information that is stored on the server, is there a prerequisite that the server stays in this country, or can we use foreign AI Scribe, for example, that stores data on a foreign server?
It depends. So it depends on the consent that has been obtained to obtain and store that information and the purpose for which it was procured. So POPI applies. It doesn't no longer apply depending on AI. POPI still applies, and it very much depends on the nature of the consent that was obtained from the patient in respect of the procurement and storage of that information.
Yes, because there's a whole concern about the POPIA data being stored. I remember reading somewhere that we are not allowed to use companies that store their data on foreign servers, and there was a talk about bringing them all into South Africa and building South African databases, data servers.
So if the consent form, which the patient concluded, and not just like a 3-page document with teeny tiny writing, they'd have to understand it, specifically consented to the information being stored outside of the country, then I imagine that would probably be okay. This is not something I've considered. This is not legal advice. I'm just using general principles. I haven't looked at that judgment. I'd be interested to see if there is a judgment on that. But using general principles, the data storage and processing is going to depend largely not only on the terms of the requirements of POPI, of the POPIA Act, but also on the terms of the consent specifically. And a generic consent is not going to suffice. You can't have a very wide consent that allows the practitioner to do whatever they like with the information. That's not going to fly.
Right. Thank you very much. So the other question is for Dr. Rattan. Obviously, building up your practice requires a lot of cost involved, and mainly for and you're going to have to recoup that cost into, you know, sort of first world patients rather than to third world patients. Are there any applications that you know that can be used that you can scale to third world country and third world use? And the other question is, does the cost of the does the efficiency and the ease of use mitigate the cost involved in acquiring these software tools in your practice? Do you think it was worth it in the long run?
So, what's the nice thing about dentistry being sort of a team profession is that, in my scenario, I love having toys. Okay. So I've got a lot of stuff in my practice that I love using, from microscopes to, design, technologies, but you don't need any of it. If you have a lab, and majority of dental labs at this point in time have have all of these digital technologies, because for the most part they're spending their day doing these sort of things, these designs, and a lot of these clinics have a lot more people that work there that have a tremendous amount of skill in using these softwares. So you could potentially just take even an analog impression. You don't need a R500,000 scanner. If you take that impression, you send that to your lab. The labs have their own model scanners, so you can put that model, for example, in their digital scanner, and that'll basically create the STL file for you. So you don't actually need to have that yourself. The technology is available at the laboratories for you to access. If you don't have access to CBCT, you can pretty much contact any one of your colleagues who does have one, and I'm sure they'd be glad to help you out with taking a CBCT. So, that's the nice thing about this. You don't even have to have chairside milling or printing. All of this can be done for you at a very nominal fee, depending on obviously the quality of the laboratory you're using.
Thank you. Thank you very much. I think that answers a lot of the question. The next question is for Dr. Pillay. They do medical aid cover, for you to utilize all these tools that you use for yourself and your practice, and also, for example, the CGM, the glucose monitoring. Do medical aid cover that? Can you claim for that, or do you have to cover all that cost yourself? And can anybody use those tools? Or I think that answer is anybody can use any tool, right? But they want to know if that can every healthcare provider use those clinical assistant AI tools? I think.
Okay, so I'll try to answer, Carolina, so don't worry. Okay, so in the EHRs, we have multiple EHRs, which can sometimes be specific to a sector, but generally the one that I showcase is the one I use, which is HealthBridge, and they have multidisciplines in them. So if the discipline is covered, then definitely the tool is built so that anyone can use them in their profession. It's not specific to general practice. It could be to any profession. So definitely yes. A lot of the newer tools build templates. So depending on your profession, you'll build the templates for what you need. So if you're an anesthetist, if you're an orthopedic surgeon, if you're a dentist, you have your templates for your EHRs, which means the AI reads your templates and understands what you specifically need. So that's definitely possible. In terms of reimbursement, not necessarily for the AI tool. Yes or no. So like Dr. Cook's, the retinal camera, medical aid, specifically Discovery, reimburses general practitioners and optometrists for doing the AI screening for diabetic patients, and they'll reimburse the AI tool in terms of diabetic retinopathy. But I think some of the other tools, that's at the practice cost, but it also means that if we're screening, we can bill a patient for screening. So if you're doing some form of a screening tool, you could bill for that as a screening tool. I often say that the screening allows us to do more and pick up more, which means then we refer the correct patient to the specialist. So in the retinal camera example, if we refer in every diabetic patient to the ophthalmologist for a checkup, which we should, only 30% are going. But if we screen 100% of our patients and pick up the ones that have diabetic retinopathy, which means 100% of the referrals then that go to see the specialists are those that are needed. So I think screening in a primary healthcare setting is very important, especially in a limited resource setting. The continuous glucose monitor, that's for patients. Schemes do fund it for type 1 diabetics, especially for children under 5 years. It's funded, and then I think for type 1 over 5 years, it's partially funded. But the price of the continuous glucose monitors have come down quite a lot. So initially it was quite expensive, and the first one that came out, this new one is half the price of the original one. And they both, huge companies like, international companies that make them. So I think the price of these devices will come down over time. And we're seeing more and more development, and this world is moving at a super fast speed. So the technology is shifting and the price is shifting as quickly.
Thank you so much. We have Anban. We have now run out of time. So thank you everybody for attending, and thank you especially to our speakers for giving us their time and expertise. Please stay for a minute longer to fill in the poll so that we have an idea of where you are and where we need to position our next talk when we organize that. So thank you very much everyone for attending. And remember, you can access this at the ATC website. The link is in the chat. So if you click on the chat, you'll see the link, and you can copy that link once the talk is uploaded, and as well as all the other talks that had happened before. So if you missed those, you can go to that website and access those talks. Thank you very much, and good night.